All right, hello everyone, and thank you so much for joining us. This is Georgie Carter from Palladium. I am delighted to welcome you all to today's webinar entitled Game-Changing Trends in Primary Health Systems. We have a great broadcast for you today, and we'll begin with just a couple of announcements. This session is being recorded, and we'll be posting the recording on Palladium's YouTube page. We would love to hear from you, and we welcome your questions at any time. And so we just ask that you submit them in the Q&A portion at the top of your screen, and the moderator will read them aloud when we pause for questions. Now, this webinar will be conducted in English, and the slides will be presented in English, but attendees wishing to view slides in another language can toggle the Translate Slides button on at the bottom of their screens. Finally, we just ask that if you are not speaking, please mute yourselves to keep the line nice and quiet while others are talking. And that concludes our announcements, and I'll pass it over to my colleague, Mark Acham, Senior Technical Advisor in Health Financing at Palladium. Over to you, Mark.
Thank you very much for the welcome. Good morning, good afternoon, good evening to colleagues and friends all over. We are very delighted to welcome you to this session. As you all know, PHC has been with us, and so for the choice of this webinar, we've chosen PHC among other reasons because it is actually the most cost-effective mechanism for meeting nearly 80% of the health needs of our population. While, as I mentioned, while this is not a new concept, current emerging trends are showing that we need to give a bit more attention to PHC. And today we have wonderful panel members and group of experts to help us digest some of these emerging trends. And we hope that your questions and contribution to these sessions would help us to find better ways to support our PHC systems. So to get started, I will want to invite Dr. Sunita Sharma to provide us with very high level reflection of some of these PHC changing dynamics that we've observed recent times. Sunita has over 25 years of experience implementing and managing complex national and global projects. He's currently the Vice President of the Palladium Global Health Practice and the Project Director of the USAID-funded project Propel Health. So, Dr. Sunita, welcome, and we appreciate to hear from you. Over.
Thank you, Mark. It's a pleasure to participate in this important discussion on game-changing trends in primary healthcare systems. The health landscape is changing fast, and we need to understand the trends and effectively operationalize impactful interventions so that we can make a difference for many countries and people in the world. So primary healthcare is not a new concept. It has been around for more than 100 years. In 1920, the Dawson Report specified PHC as the first level of healthcare. The report coined the concept of PHC as the entry level for more specialized care. The tradition of general practitioners as the gatekeepers of healthcare has evolved. Many countries have since adapted this approach. Famously, the 1978 Alma Ata Declaration put PHC on the global agenda. In 2018, just before the pandemic, the Declaration of Astana renewed country commitments to PHC. The COVID-19 pandemic showed that our PHC platforms are fragile due to low investment and weak performance. With the realization, for the first time now, countries, funding agencies, and experts are aligned and committed to refocus on primary health care. This is a great opportunity for us to make the difference this time around. With this renewed focus, we can make people-centered, high-quality, sustainable primary health care a reality. So what new elements can bolster the primary healthcare agenda and catalyze change? I would like to bring to your attention 6 emerging game-changing trends. First, the SDG deadline is fast approaching. The 2030 agenda focuses on primary healthcare-led universal health coverage. Next, the emerging global threats such as pandemics and climate change required an articulated health sector response. Of course, reduced fiscal space due to slower economic growth necessitates a focus on efficiency. Also, the changing landscape for external funding is leading to integration of vertical programs. As we all have seen, advancements in digital health technologies are enabling patient-centered care delivery. And finally, we are seeing growth of chronic conditions. And these chronic conditions require an approach that is much more integrated across the continuum of care. So how significant are the game-changing trends? Well, key SDG 3 indicators are lagging. As you see in the graph, reverting maternal and child health trends and reduction in life expectancy are most concerning. Also, 4.9% of the world's population is pushed into poverty due to catastrophic health expenditures. Additionally, the global threats are affecting our efforts towards eradicating poverty. For instance, 70 million people were pushed into extreme poverty by COVID, and 41 million people are dying from communicable diseases annually. The reality is that current economic challenges are putting greater restraints on the fiscal space. An estimated 3% fall in global economic growth is expected by close of the year. By 2027, health spending capacity is expected to reduce between 15 to 30% in at least 41 countries. This will be lower and middle income countries where external aid has plateaued or decreased in the last couple of years. But the evidence is not all gloom. Some positive trends can be observed in investments made in digital health solutions and the community workforce. For instance, primary healthcare system can provide 80% of a population's essential health needs. Up to 15% efficiency gains can be achieved using digital health tools. And every dollar invested in community health workers yields a $10 return on investment. Telemedicine took a long time to penetrate the health system in many countries. The pandemic expedited telemedicine in a very important way. So in this slide, I would like to highlight how these game-changing trends have positioned the primary healthcare agenda. With countries unlikely to meet SDG 3 by 2030, many are now concentrating scarce resources on PSC-based essential health benefit packages. These tend to be the most cost-effective approaches to achieving universal health coverage. Countries that had stronger PHC systems were better equipped during the pandemic. That was our wake-up call. Preparedness efforts to tackle future threats must prioritize strengthening the primary healthcare systems. Hospital-level care is resource intensive. If we build our primary healthcare facilities to be the first stop for all non-emergency cases, then hospital resources could be needed for more specialized care. In addition, the The move away from donor-funded vertical programs has increased the need to mainstream these interventions into primary healthcare. There is a growing consensus that strategic and innovative use of digital and cutting-edge technologies is an essential enabler for UHC. And finally, aging and technology have transformed the nature of healthcare from episodic to chronic. Chronic care means primary healthcare services should be at the center of patient care. So we seek to improve health outcomes. What are the pathways that link these trends to strategic approaches? Here are some of the strategic approaches Palladium has been focused on. So number one, design and operationalize integrated, focused healthcare models. Two, operationalize efficiency and equitable financing at all levels of the health system. Three, strengthen primary healthcare system readiness, response, and resilience to shocks such as epidemics, pandemics, climate change, and migration. Four, promote and institutionalize integrated digital and analytics solutions across the health system to ensure better and evidence-driven decisions and care provision. And strengthen, number five, strengthen subnational health system management to ensure better governance and accountability at all levels. So in the next session of this webinar, my colleagues will dive deeper into health financing, human resources for health, and integrated analytics and digital solutions. I think you will find it interesting and thought-provoking. So back to you, Mark.
Thank you very much, Sunita. Thank you a lot for providing the context and sharing really, really important trends that, really going to be shaping or is shaping our current PHC agenda. I think that one of the critical things that you highlighted included, the fact that the SDGs are approaching very fast and countries have to, adapt, their indicators and approaches towards universal healthcare. And PHC has been at the back, at the front of this approach. Of course, the threats and the challenges, including the pandemic, the fiscal space challenges that we're facing, all of these really mean that we have to find a very effective and efficient way of providing the health needs for our citizens and population at large. In the next presentation, I would be inviting one of our colleagues in the person of Dr. Eduardo Gonzalez-Pierre to share how the emerging health financing trends are shaping the current PHC systems. Eduardo is a trained economist with over 25 years of experience in health and social security. As a senior technical director of health financing at Palladium, Eduardo is responsible for providing technical leadership to countries in low-income and middle-income countries to effectively engage in domestic resource mobilization, putting in place sustainable financing mechanisms that will help us and accelerate our efforts towards universal healthcare. So Dr. Eduardo Gonzalez-Pierre, thanks for joining us today, and we would like to hear from you. Over.
Thank you, Mark, and thanks for the opportunity to be here and sharing some thoughts. So I would be going over some of the details of how these trends can affect the strategic pathways that Sunita just mentioned, and I'll be talking specifically about health financing. So these trends that we just heard about, they provide different context, and this different context is both an opportunity to catalyze PHC, but it is also a challenge in the way we traditionally do health financing. So let me go over some examples of how these emerging challenges in the way we do health financing can have some responses on the technical part. And one of the examples, the most obvious one that comes to mind is the need to focus resources and attention to PHC. And there's a set of financial mechanisms that work towards that, making sure that health systems prioritize PHC and have the budget move towards those levels of care. One example of that is making the investment case. So we need to help health systems, governments, ministries of health to make a very persuasive, compelling case that preventive care at the PHC level, gatekeeping is not only good for health, but it also saves money. A second example is about multi-sectorial collaboration. We've seen that the new challenges have to do with tackling successfully pandemics and climate change. That requires a lot of multi-sectorial collaboration, and multi-sectorial collaboration will require multi-sectorial budgeting. But right now, the way multi-sectorial collaboration is financed is basically through line items which sit in the budgets across the different ministries. And one of the things that we have to innovate is to make sure that these budgets, which are fragmented, sit together, work together, maybe something that is much more comprehensive and inclusive to incentivize multi-sectorial budgeting and multi-sectorial interaction. A third example is about autonomy. We talk a lot about making PHC levels more autonomous, more in charge of the decision making. But what we forget is that providing autonomy is also expensive. You need to have the managerial capacities. Most of these countries don't have the trained accountants to do that. And one of the important things to do in health financing is to understand where the right balance is. Make sure that PHC has more autonomy. They can manage their budgets, they can manage their financials, but not necessarily impose a very expensive structure at the PHC level. So that is a challenge and something that has been worked on. I'll give an example of a country that is progressing around those lines. The fourth example is about integration. We hear a lot about integration, especially associated to countries which have graduated, moving towards self-reliance. Vertical programs have to be integrated into PHC. And we see that with essential health benefit packages, which integrate the interventions from family planning, HIV, other vertical programs. But the biggest problem here is that the health benefit packages are usually disconnected from the budget. And what we need to do is get the ministries of finance much more involved, not only at the end stage where you come up with a package of interventions and try to find the money, but in the design and the prioritization stage of the process of health benefit packages. And finally, the private sector. We cannot forget that in many countries, 50% of PHC is privately paid for. Sometimes countries have 70-80% of ambulatory care is borne by families and households. So we need to integrate the private sector into these strategies. We need to work with the private sector. That requires the private sector to be the solution, not necessarily the problem for out-of-pocket payments and excessive or catastrophic health expenditures. And we need to work on the contracting arrangements to align these objectives. So let me briefly give you a few examples of the things that are happening. Countries are already taking action. They're looking at things and responding to these trends. Let me quickly go example of Ghana. Ghana is one country that has gone through important health financing reforms. In recent years, they have managed quite successfully to integrate vertical programs into PHC and into the National Health Insurance Scheme. And they have managed to integrate external funding and domestic resource funding to provide a service for the National Health Insurance Agency. So that's a good example of things that are already taking place in Ghana in terms of integration. In the case of Botswana, they have committed to revitalizing PHC. PHC was once decentralized, it got centralized 15 years ago. Now it's going to be decentralized again. They put together a technical working group. They're kickstarting very intensive work, and they're starting with the investment case of PHC, which I think is something that is going to be very compelling. They're trying to make a case, especially on community health and community health workers. Then we have the case of Kenya. I won't talk much about Kenya because we have a panelist from the Kenyan Treasury. But Kenya is an excellent example of good collaboration between Ministries of Health and Ministries of Finance. It is about providing sustainability for PHC funding over the years. And then finally, Rwanda. Rwanda is an excellent example of decentralizing smartly in terms of adapting PFM mechanisms to PHC. How do you bring in managerial capacities? They've worked with hiring certified accountants, some of them working at the district level, some of them working at the facility level, some of them taking care of the more transactional processes at the facility level, and then more the budgeting and the PFM that connects with the central level at the district level. So these are very interesting examples already taking place, things we have to listen to, watch carefully, learn from, and make sure that we get the practices right, we evaluate, and we share the best learnings across the different countries. So back to you, Mark, and thanks.
All right, thank you very much, Eduardo, for those highlights. I think you've really highlighted some of these key opportunities, especially in collaborating, the collaboration between national governments and decentralized governments to find, best mechanisms of really allowing our facilities to operate in a transparent and accountable manner. In our next presentation, it will be Thomas Miner. Thomas Miner will be sharing some of the HRH related engagement that are really providing opportunity to scale up our efforts in the PHC level, and he will be sharing specific examples from Uganda. Thomas is a health economist by training. He has over 20 years of experience in the field of healthcare finance and health system strengthening. And currently, he's a chief of party for the USAID-funded Ugandan health system integrated health system strengthening project, which is being implemented by Palladium. So, Thomas, if you could kindly help us to appreciate how HRH, as well as community engagement, is driving our efforts at the PHC level. Over.
Thank you very much, Mark, and good morning, good afternoon, and good evening, colleague. I must say that I'm excited to be part of this webinar that is focusing on PHC. And mine is very simple, to try and articulate some of the technical approaches that we can leverage on the game-changing pathway to strengthen human resources for health and community engagement with the goal of achieving primary health care. We all know that a health system capacity to manage essential health services and respond to emergencies is dependent on the availability and readiness of health workforce. And for us to strengthen the capacity of the health system to respond to essential services, we need to do a couple of things. And this is what I want to articulate briefly. First, we need to address human resources for health gap, and we can do this by taking advantage of workload indicators of staffing needs. We can combine this analysis with prioritization and optimization analysis, and all this effort is geared toward supporting high-level advocacy with policymakers, and this will aid recruitment and deployment based on availability and staffing gaps. We can also enact safety measures and mental health support for clinical staff. We can also improve skill mix on teams and build staff competencies in digital technology. The next is focusing on key policy levers that will lead to efficient utilization of health workforce. And this will ensure that the workforce is able to deliver a high quality PHC services and meet the health system goals that include maximizing the scope of practice within multi-professional PHC teams. Next is to build capacity of countries to conduct key critical analysis that include health labor market analysis, health workforce planning and focusing. All these are geared towards generating data that can be interpreted to generate the human resource workforce demand and supply. And on the basis of this data, country can start now building investment cases for HRH and community health strengthening. Countries can also adopt approaches that include strengthening capacity of the already existing HRH department units, and this is with an effort to promote effective intersectoral collaboration so that within this platform, countries can be able to push the health in all policies. Countries can also focus on different policy options. These policy options include targeting skill mix. For instance, introducing new types of workforce, multidisciplinary PhD teams with public health function embedded at the PhD level, and also ensuring engagement close to the community level. Country can also strengthen these HRH units or department so that these department are in a position to lead policy development, implementation, and also monitoring to ensure that there is improved working condition, work environment for better staffing ratio. On community engagement, I think the specific focus should be building capacity of MOH, including the community health department, to be in a position to generate evidence-based policies and strategies to make available to the ministry some of the critical tools that can be able to aid advocacy for increased investment, because we all know very well community health is a cost-effective approach that will ensure access to to PHC services. Now, I want to jump into some of the activities or interventions that are happening here in Uganda. And I want to look at specific examples. For the last couple of years, the country has been involved in development of human resources for health specific policies and plan. We were able to work together with MOH and other partners to be able to provide the necessary data, including application of the workload indicator for staffing norms that is able to generate data that is able to inform development of these policies and plans. So we have now a 10-year training plan that was basically informed by data that was generated from some of these key important tools that include the integrated health information system. We have been able to work together with MOH to generate data on HRH planning and focusing. And on this, we have been able to work with MOH to apply some of the available tools, just like what I've been able to mention, the WISN and the IRIS, which are very important because they link workforce to population need. We have also been working closely with MOH to generate analytics and evidence that can be used to advocate for increased investment for human resources, and also for community investment. Some of the critical analytics we have been able to generate include the HRH audit reports. We have done that for a couple of years, and we are currently piloting the community health workers extension pilot. This pilot will generate a very important piece of information that will inform programming and investment on community health workers. We have also been focusing on capacity development, working together with other partners. And on this, I can be able to isolate some critical capacity building that we have UHSS has been focusing on, and want to talk to basically pick on training and tooling of the community health workers that we recently provided to the community health workers. And in this particular case, we wanted them to be in a position to detect and respond to any public health emergency. So capacity building with a focus of reorienting the HRH staff and also community health workers to respond to emergency is going to become a critical technical approach that countries will be able to need now in the medium term and also in future. The other focus has been on information systems and data solution. And here we've been looking at establishing surveillance systems and tools for public health emergencies. These are some of the areas that we have been focusing on, working with other partners to make sure that the country is able to leverage on some of the game changers that have been highlighted by the previous presenters to be able to strengthen HRH and also community engagement for improved primary healthcare services. And thank you very much, and back to you, Mark.
Yeah, thank you very much, Thomas, for those really insightful country level experience on how you are adopting your policies and processes to ensure that we are using the opportunities within the PHC systems optimally. As you had ended on digital solutions, I think that would position us really well for our next speaker. Our next and final expert speaker would be Teddy Beremhund. He would be discussing how information systems and technology is integral in strengthening our PHC system. Teddy is a digital and information systems expert with over 15 years of professional experience implementing and managing projects including mHealth, supply chain information systems, digital health, and e-health infrastructure. He's currently the director and portfolio lead of information systems at Palladium. Teddy, we would appreciate to hear from you how you had, observed systems and technology adapted across, some of the areas you've been working in, and advancing PHC in a very effective and cost-efficient manner. Over to you.
Thank you very much, Mark. Really appreciate it, and thank you for the colleagues who, as you have seen, have highlighted some of the importance of data and digital in the space of PHC. So just to summarize, we can look at the impact of data and digital from two dimensions. The first one is, as alluded and highlighted by my colleagues, in all of these game changers, whether it's policy or HRH or other issues, I think digital is an enabler that can help expedite some of these integrations and efficiency gains within each of these sectors. So in HRH, you've seen IHRIS and others, but also in finance, the same thing. It is an enabler that can really allows you to make more efficient primary healthcare systems. But in its own stand, digital and data can also be an intervention, as we have seen in many places, especially in the past pandemic during COVID. With the new and emerging technologies that are coming and being introduced and being widely used to the communities, like telemedicine, electronic medical health recording, wearable devices, most recently AI has been playing a significant role in our daily lives. So if we have identified the right technology and the right systems to integrate in the primary healthcare level, one of the things we can ensure is getting really real-time data that can be used to inform decision makers at the right time, and really gain efficiency in terms of work burden and reduce some administrative tasks, and improve the efficiency of overall the PHC level. So looking at either efficiencies to gain in physical space, or whether in expanding the reach of the PHC through virtual mechanisms like telemedicine or personalized care like wearable devices, or really looking at a comprehensive view of data from multiple sources using AI-powered chatbots and alerts to really focus on patient care at the primary healthcare level. Digital plays a significant role. Sorry about that. So one of the other things we have seen is during the past pandemic, addressing global challenges, investments in digital and data systems that has been made previously have played a significant role in really able to control the pandemic by providing close to real-time data and information about how the pandemic is changing, what the status of these diseases are, mainly from a primary healthcare perspective. So overall, the impact of digital and data is significant, and in terms of really improving the primary healthcare level in physical space and efficiency. What I would like to do next is to walk you through some of the examples of the work that I have, and I picked two, and then we can have looked at many others. I will start with the one at the bottom, Guatemala, where how data can play a key role in improving efficiencies and assigning the limited resources that we have at PHC level in a more informed way and targeted manner. So the issue in Guatemala was there is a budget planning that happens at the Ministry of Health, but the financing data is sitting at Ministry of Finance. So we have assessed what are the issues in the systems. There is no data exchange between the data that resides at the Ministry of Finance and the data that the ministry is using, at the primary healthcare level. So that integration is through an API and had allowed us to closely work collaboratively with the both stakeholders, Ministry of Finance and Ministry of Health. And we also take into consideration, in all of our designs to make sure that it's a sustainable way and feasible way of integrating the systems. And we are able to extract some of the data from Ministry of Finance that's relevant to PHC and integrate it within the existing MOH health information system. And the result is we have able to have data accessibility at the Ministry of Health level during their planning. And there is a significant achievement in terms of positive impact in the primary healthcare level in Guatemala by enhancing quality budget expense, enabling targeted investments, especially an improve in basic medical services as well as infrastructure and equipment investment, because of the saving that they are able to identify and able to target through this intervention. Another great example I can mention is in Eswatini. And in Eswatini, as you can see up there, we were able to enhance and scale an integrated primary healthcare EMRs. This shows the significant role digital can play instead of having a parallel vertical programs only for HIV, for TB and malaria. The way the EHR and the CMIS is integrated in Eswatini is a very good example of to show how vertical programs can converge using digital tools and data as an evidence. So if you look at Eswatini currently, 95% of the health facilities there log into the CMIS to do their day-to-day primary healthcare service provision, which has significantly reduced the task and burden that each healthcare worker at the HC level is facing. 77% of the HIV treatment patient also get covered through these systems, and so we have a comprehensive view of the patient. So as a result, there is an effective linkage of clients and client information with health facilities within the cascade of the primary healthcare provision from community to facility and so on. We are also able to ease the access. It's easy to access now given the dashboards and the analytics view that are created embedded within the CMI systems. And portability, really, patient referrals and linkage. We don't have to carry paper documented trails from one end to the other end. So as a result, there is a real-time access of information that really significantly improves the efficiency of the service delivery at the PHC in Eswatini. So these examples, whether in data or digital tool, when they are selected the right way and integrated at PHC, they will be able to allow us to enable some of the game-changing trends to be really facilitated, as well as by themselves enable us to gain efficiency within the system at PHC level. Back to you, Mark. Thank you.
Thank you very much, Teddy. And I want to say a big thanks to Sunita, Eduardo, Thomas, and Teddy for really bringing us up to speed and getting us to understand what these game-changing trends are. Over the few minutes of discussion, we've heard, some gloom statistics, but also very insightful opportunities that we can draw from. For instance, we heard that by investing in community health workers, for every dollar spent on them, we're getting $10 in return. I think that is really a powerful message. But even more so is the fact that nearly 80% of the health needs of the population can actually be provided at the PHC level. Now, with that, background information, I have the privilege to now introduce to you our esteemed panel speakers. And today joining us would be Dr. Henry Mwebesa from Uganda. He is a medical doctor who had worked with the Ministry of Health for many years. Over 20 years experience supporting both national and subnational level engagements under the ministry. He is currently the director in charge of health services. He has been involved in planning and supervising various health programs and activities at the national, regional, and district level. A large section of his career was spent at the national level, building quality and performance improvement systems in the health sector. Our second panelist would be Dr. Mai Hajazi. She is the director of the USAID Office of Health Systems at the Bureau for Global Health. She recently served in the USAID Office of HIV and AIDS as a division chief for Health Systems and Program Sustainability Division, where she led technical branches covering finance and economics, health workforce, transition to local partners and private sector approaches on advancing USAID's role for HIV, sustained epidemic control, as well as support the health system, strengthening interventions as a whole. We are very privileged to also have Ms. Judith Oyango. She is a principal economist at the Department for Economic Planning under the National Treasury and Economic Planning. She has experience drawn from sub-county to national economic planning. Her current role involves coordinating development of national and sectorial development plans for the Kenyan Vision 2030. She also performs functions including monitoring, evaluation, and reporting on national development programs and projects, including the African Agenda 2060 and 2030 SDGs. She performs other functions, including tracking implementation of programs and projects under the multilateral and bilateral economic partnership. She coordinates the national budgeting under the midterm expenditure framework. Lastly, but not the least, on the panel is Ms. Christina Yaro, who is currently the Director of Primary Healthcare at the USAID. She had previously worked as HP Plus Indonesia Country Director, where she led various innovative interventions, including building the capacities of government partners to find sustainable mechanisms of finance in the health sector. Prior to that, she'd worked with the Asian Development Bank as well as the United Nations Foundation. We are privileged to have these very experienced and knowledgeable experts in the field of health system strengthening and primary health care, as well as the health sector in general. And I would quickly want to hear from them, just in general, to set the ball rolling. And please, our participants online, if you have questions, please send in your questions by writing them in the chat box. But before then, I would want to invite Dr. Henry to share his quick perspective or impression about these game-changing trends that have been presented. Over to you, Dr. Henry.
Thank you very much. I hope I'm on now. Thank you very much, Mark. Yes, first of all, I really want to appreciate that we've been invited to participate in this and to share our experiences. I want to thank the earlier presenters who gave us the background information, which is very critical for our discussion today. We are looking at the human resource for health and the PHC services, which are very critical elements in our country. If you look at the human resource for health and the PHC services, the human resource for health is a very, very critical element or building block of the health system. So we take the human resource for health as a very, very important component of our system, and we really prioritize the health workforce in our country, right from the community level up to the national level. At different levels of care, we try to strengthen our human resource for health, including actually even the community health interventions. And the PHC approach is the way to go, especially for us in developing countries. With the resources which are limited, we want to utilize the PHC approach in order to benefit most of the gains in our health system. As we have already seen recently, even in the epidemics, we find that the PHC approach and the role of the community are very, very strong approaches to address the challenges. Mark, do I go ahead and also highlight a few examples of the interventions that we are doing to strengthen our health?
Right. I mean, you can hold on for now. Just let's get a quick round from the other panelists. Dr. Mai, if you also have a quick perspective to some of these game-changing trends that were presented. Over to you.
Yeah, thank you. Thanks so much, Mark. And thank you, Sunita, and thanks to Palladium for inviting me to be part of the panel today. Very happy to be a speaker and part of this discussion. All of the themes really and topics that were highlighted as part of the intro presentation resonate very closely with the priorities that we are also working on through our Office of Health Systems. And I think nicely highlight the challenges that we need to be focused on moving forward. I will say, in many ways in this post-COVID period right now, this past year has really been a year of recommitment to PHC. We've seen this as global leaders have reaffirmed the importance of PHC and UHC in the G7 and G20 deliberations, during the UNGA Assembly back in September, through the International Primary Health Conference that was held in Addis Ababa, and more recently, just this past month, at the World Health Summit in Berlin. PHC has also been a core theme at the WHO regional meetings this year, highlighting the importance, and I think just even the expression of country leaders, that this is an area that needs attention. Dr. Atul Gawande, our Assistant Administrator for the Global Health Bureau, has used these global platforms to emphasize the need for greater donor alignment with countries and also local partners in order to help catalyze change toward the alignment and toward more integrated approaches to strengthen primary healthcare platforms and also health systems overall. I'll stop there and look forward to the discussions as we go through the different questions. Thank you.
Thank you very much, Mai, for those very high level feedback on the PHC in general, as well as, of course, the game-changing trends. I will now invite Judith to also do the same. Give us your immediate impressions about these game-changing trends, how you how you relate with them, what you think about them in the course of your current work, and how is that, you know, impacting or leverage in the context of Kenya. Over to you.
Thank you very much, and Mark, and thank you to the previous speakers. Indeed, it's very wonderful to join you in this discussion. And I'd like to echo what the previous speakers have said. The issues of health financing, human resource for health, and integrated human management information system are critical in this journey towards UHC. And it also informs what we're undertaking as a country in reforming the health sector to ensure that we have affordable, equitable, and quality healthcare services. I'll be elaborating on the same in the course of this discussion. And as has been said, the investment in PHC is the way to go, and it's expected to be the most efficient and cost-effective way in organizing our health system, a lesson that we learned from the COVID-19 pandemic, and in the context of competing needs, shrinking physical space, and the need for efficiency in health spending. Thank you.
Thank you very much, Judith, for those really apt and concise response and feedback on the general question. I mean, the general presentation this morning. So now to the specific questions, and as we also assemble the questions from our participants, I will want to come back to you, Dr. Henry. Can you now, you know, as you were asking, can you now highlight some of these HR or human resource, you know, interventions or capacity building that you put in place in Uganda to ensure that, you know, the PHC systems are more effective and efficient in the services they provide? Over to you.
Once again, thank you, Mark. As I said in my earlier introduction, we take the human resource for health as a very, very important component of the health system, and we have been trying to strengthen the human resources of the health workforce right from the community up to the national level. Let me quickly start with the upper levels of care, especially in our facilities in the health system. For instance, recently we have even revised our staffing structures to address the human resource gap in our health facilities. We have more or less doubled our human resource levels in each facility or at each level of care, and even strengthened their remuneration so that staff can be able to provide the results that are expected for each level of care and to be available to work all the time, but also against very agreed outputs so that our people can get the services that they need, from the lowest facility up to the national referral hospital. We have also worked very closely with our colleagues, like the USAID, Uganda Health System Strengthening Activity, UNICEF and WHO, to digitalize the health workforce performance, like through the IHRS, in order to track the attendance of our health workers, and also to get a quick snapshot of the human resource who are available and where. Like I told you, I'm in one of the most rural districts in this country. But before I came, I could tap on that system and look at the human resource in this district and anticipate the discussions that I would have with the district health teams here. So that system is helping us, but it is also helping us. We want to take it even further to see that can it be linked with the other packages like DHIS2 and other systems to see that we can detect, peak the outputs. We are also working with the USAID UHSS project, for instance, to develop key performance indicators. If I have a doctor at this hospital which I've been visiting, I would want to know in the last months of this year, what did you do exactly? What are we as government paying for? What are the outputs of the medical superintendents? What are the outputs of the doctor on the ward? What are the outputs of the nurse? So we have developed that system of key performance indicators so that it's not just a question of coming and attending, but I also want to know what are the benefits or what are the outputs of your being here. And in all this, we are being supported by different strategies and policies that we have developed, many of them which were highlighted by Thomas in his presentation, like the 10-year Human Resource Strategic Plan, like the 10-year training plan, like the 5-year National Community Health Strategy, and also the Human Resource Landscape. And we are trying to align all our priorities in human resource, our investments and training in that through those interventions. Quickly, at the community level, we are strengthening the community health workers so that because most of the diseases are most of the diseases come from the community. And it is our saying here that most of the diseases are prevented and addressed at the community level. Our focus is to prevent diseases and promote health. And this can be best done at the community level. In that context, we have developed the community health workers, whom we call the community health extension workers, who will be able to undertake most of the services at the community level, including preventive services, health promotion, and even disease prevention, including epidemics. Like we saw, we worked very closely with them during the COVID pandemic, and they were helping us in surveillance, they were helping us in education, and they were also helping us in other outbreaks control. But they also help us in the area of, for instance, referring mothers to hospitals, and they work very closely with our health facilities. So in a nutshell, we are strengthening our human resource right from the community level through all the levels of care up to the national level, including training of specialists. Thank you, Mark.
Thank you very much, Dr. Henry, for those real examples and tangible, support you're providing at the very community level to ensure that our health personnel are providing really quality services. I'm particularly excited about the fact that you say you're remunerating them properly and also now defining standards, performance standards, to make sure that they are guided by some real accountable matrices. The next question I will pose to my question to you would be, given the current all these opportunities as well as the challenges presented, how do you see data or digital innovation as really contributing to this, to strengthening our PH systems? And are we really equipped to provide? I mean, are these current PHC systems? Do you think they are well equipped at the moment to provide, the full continuum of care as we have been advocating? Maybe I rephrase the question. How can we leverage the data and digital innovation systems that we currently have to strengthen our PHC systems? And to ensure that they are able to provide the full continuum of care that we advocating for. Over to you, please.
Great, thank you, Mark, for that question. And I just want to acknowledge Dr. Webesa's response as well, because I think he actually touched on some very practical examples in reference to this question as well. I would say that in our current approaches to strengthening primary healthcare platforms and strengthening health systems, as we think about digital solutions and digital innovations, it is about data, but it also gives us an opportunity to think about how to apply those innovations and new and emerging technologies, I would say, in our traditional intervention areas, such as financing, health workforce, pharmaceutical systems and pharma regulation, even this new emerging area of regional manufacturing, bolstering health information systems, and very importantly, also supporting our commodity and supply chain systems. I think my main message here is that even as we look at these traditional WHO building blocks for health systems that really support strengthening primary healthcare platforms, we should always be looking at where those innovations can come in. We know we live in a world of big data. It runs our lives in many ways, and we have, in some places, extremely sophisticated systems, and in other areas, especially in the health systems in the countries that we support through USAID, where these systems still need to be developed. I had the opportunity to attend the WHO Afro meeting in Botswana back in August, and it was really amazing to hear all the ministers speak about the importance of PHC, but also, a clear articulation of the interest in ensuring that the digital health space grow as well in terms of our donor investments, including with new and innovative technologies such as AI. So that means we have to think about really how to invest in those systems across our PHC platforms, how to make sure those types of investments are not just small pilot type projects, but are projects that can be sustainable in the long run, and kind of really meet and keep these countries also in the cutting edge space as these technologies evolve. I will just take a moment to say that as we at USAID now look at how we can do this, we know, I think everybody knows at USAID that we have multiple vertical programs: malaria, HIV, family planning, maternal child health, tuberculosis, global health security. We do have a significant opportunity here to look across all of those programs and say, what are some of the common areas where we can invest together to help really move these innovations forward? And that's something that we're working on internally at USAID, and really is an exciting area for us to be thinking about for the future. So I'll just stop there. Thank you.
Yeah, thank you very much. I think you've really touched on very insightful topics, and I think I would want to emphasize the need that, with these digital solutions, we'll have to focus on also, using some of these innovations and leveraging them for some of our traditional areas. You've mentioned supply chain, workforce, health workforce, health financing as well. And I think your last point is very, very profound, in the sense that, typically we'll have, disease level vertical programs working in silos. And the call here, as I hear, would be, how do we work together beyond, our targeted interventions to find really, solutions that can help us collectively move towards providing, I think, ultimately quality healthcare for the general population. So with that, I would want to move to the next question. And the next question will be to Judith. Judith, my question to you, given the fast approaching SDGs, of course, the deadline, and the limited successes that we have achieved, especially on financial protection for our population, can you highlight how Kenya is ensuring that the general population is able to access quality, essential healthcare without exposing them to financial hardship? Over to you.
Thank you very much. As a country, we've made various attempts towards UHC, being one of the aspirations of our Kenya Vision 2030 under the social pillar. And this is well articulated in our constitution, and it's in line with the goal 3 of both the SDG and the Africa Union Agenda 2063. So in this decade of action, as a country, we have an obligation to ensure that our health sector provides equitable, affordable, and quality healthcare of higher standards to all our citizens. And to achieve this, we need increased efficiency and equitability in financing, a journey that will began through our medium-term plan 4 of the Vision 2030 and the Kenya Health Policy 2014 to 2030. So currently, we've identified healthcare as one of the core pillars of our bottom-up economic transformation agenda, and specific areas of focus for our country are health financing. Under health financing, we intend to increase the coverage of households under the social health insurance from the current 24% to around 80% in the medium term, and possibly to 100 by 2030. We also want to consolidate fragmented insurance pools and funding, covering the indigents in the informal sector, as well as enhance the health benefit packages which we intend to review maybe by every 2 years. We also have an area on health commodity security. We need to ensure that we have access to safe and affordable health products in all our health facilities. There's also integrated health management information system in line with the technology. We cannot run away from it. Fourthly, we have human resource for health. We want to equip our facilities with the requisite health personnel to be able to deliver on our agenda. And the focus right now is on primary healthcare through the community health promoters, which has been alluded to by Dr. Henry in his remarks. And we also want to improve our health infrastructure. So some of the key major milestones we've had towards this health financing is enactment of the new Social Health Insurance Act, which establishes a primary care health fund. It also establishes a social health insurance fund to ensure that all our citizens are covered in terms of access to healthcare. We also have the chronic, emergency, and critical illness fund. This will be able to defray the costs of once you deplete the social health insurance fund. And all these funds I've mentioned will be financed publicly through domestic resources. We've set a flat rate of per household, regardless of their income, so they have to contribute to financing of health. So the Act itself provides hope in access to healthcare because it will be based on the needs of Kenyans and not their ability to pay. And it will further address the issues of high out-of-pocket expenditure that has been a burden to the households and thus limiting their access to health services, particularly for those who are not financially secure. And then also shifting from curative to preventive and promotive healthcare, which is being driven by community health promoters at the community level. And we are going to equip them with the requisite skills and training to be able to undertake their work at the community level. This will be a joint collaboration between our national government and then involved function at the subnational level. So those are the major things that we are doing as a country to ensure that we don't strain our citizens in terms of access to healthcare. Thank you so much.
Thank you very much, Judith, for those for the highlight. And I think later on I will come back to this, the question that I posed and the response you provided, especially on the Social Health Insurance Act. I think there's a question on the chat which would need further input. But before then, I will come back to with another question. How do you envision the future of vertical donor-funded programs, especially in the current shifting and renewed interest in PHC? I know you started, maybe you touched on this conversation already in your first response to my question, but what is your vision with vertical funded projects moving forward in the context of PHC?
Yeah, so thanks, Mark, and I'm happy to elaborate on that a little bit. USAID these days is very much focused, I would say, on advancing the primary healthcare agenda. And I think we're working really hard to think about how do we best do that. And that means for all of us across all of our programs, all of the vertical programs that we support as an agency, and these vertical programs are really critical programs, whether it's for HIV, TB, malaria, maternal child health, family planning, et cetera. And so we don't want to say we don't need those, but I would say the real opportunity is how do we take these programs, align them so that we can collectively be strategic to strengthen primary healthcare platforms, but also to improve systems, health systems overall. And I will say there is currently, I would say, an opportunity that we have that we're very much actively working on in the Office of Health Systems. And my colleague, Christina Yarrow, will speak more also to primary impact in terms of what we're doing there for our PHC agenda. But within the Office of Health Systems, for the past couple of years, we've had a new directive in place, a new congressional directive that basically says that at the country level, as our missions implement their vertical programs, they really should be looking to take about 10% of the funding for each of those vertical program areas and investing those funds in cross-cutting health systems interventions to strengthen the health system as a whole. So for me, in terms of how we can work as the US government, this represents a fantastic opportunity. It represents a game changer in terms of where we have this window now through Congress to say, how can we work together across our programs to really strengthen health systems? And when we strengthen health systems, we also strengthen primary healthcare platforms. So there is also, along with that, a clear opportunity to align this 10% HSS funding directive with our goals for strengthening primary healthcare platform. And that can come in many forms. Many of them have already been highlighted, whether it's developing country social health insurance schemes, whether it's building out community health worker cadres to reach communities, especially communities that don't have easy access to facilities, whether it's strengthening the HRH, the health workforce overall, whether it's really supporting new technologies in the digital health space, or even really advancing regional manufacturing beyond, I think, the core hubs that we saw were predominant in the pre-COVID era. We know that that's an area that has to change. So as we think about this 10% directive for HSS, it really aligns well with also what we want to do to strengthen primary healthcare platforms. Thank you.
Thank you very much. I think that if our other colleagues on the other side, beyond the USAID, I mean, this congressional directive, I think what this has really opened up is the opportunity for the other vertical programs outside the USAID arrangement to also consider how, you know, we can join our efforts, even whilst we are also tackling the disease-specific interventions. How do we strengthen our health systems to ensure that, you know, these programs make the needed impact? My next question would come back to Dr. Henry. Do you think, and that's a follow-up question actually, from the fact that we have need for more resources and so forth, do you think our current PHC systems are at a level where they can actually provide the full continuum of care? I've heard, you know, the wonderful things you're doing in Uganda. Do you think we are at that level where, you know, they're able to provide the full continuum of care? If so, you know, you can highlight. If not, what are some of the key interventions we can collectively work together to make sure that they are ready to provide these the full continuum? Over to you.
Once again, thank you very much, Mark. But before I answer your question, I'm happy to note that all of us are talking about strengthening health systems, because that's really very, very important. And that's the way to go for us, especially the developing countries. Back to your question, I believe that the current PHC systems are really not yet at that level of covering the full continuum of care. I think I must be honest, we are not yet there, but we have done a lot of progress. There has been significant progress made in that direction. I'll talk in particular about Uganda. Guided by the Declaration of Almata in 1978 and the recent Astana 2018 recommitment, as Uganda, we have been focusing and strengthening our community health interventions, our PHC approaches, to be the major strategy of strengthening our health systems in this country. And in that context, we have, first of all, a very strong political commitment towards that goal, right from the top leadership of even His Excellency, the President himself, and the ministers and all the district leadership. Like currently where I am in this district, I want to keep giving it as an example. Where we are here now, we are moving together with the local government, political leadership, with the cultural leaders. We are working with even the religious leaders to see how do we strengthen our health service delivery, taking into account that we need to involve everybody, and health is not the role of the health sector alone. So that approach is very, very important, and we're trying to strengthen that even more. But also, if we are to achieve a lot, and we are doing this, for instance, in Uganda, we are emphasizing more on funding the PHC system and services. For instance, now we are going into more into supporting or funding the preventive services and the community health interventions, issues to do with immunization, prevention of NCDs, prevention of communicable diseases, and all the interventions at the community level. Because our belief is the diseases start in the community and they must be controlled and prevented in the community. So we are trying to emphasize that and working very closely with the community. So our budgets are more aligned towards primary health care. But related to that, also the issue of efficiency. If we are to achieve more, we need to be more efficient with the resources that we have, because resources are not increasing. The best we can do is to do better with the resources that we have. And in a related way is the issue of integration of services. Mark, if we are to deliver services, we need to be more integrated and reduce on this problem of disease-specific interventions. We have to strengthen our community interventions, and we also have to strengthen quality standards to make sure that what is being delivered in one end of the country is being the same standards being delivered in another end of the country. So we have worked very closely with USAID to develop standards and strengthen community health interventions, to strengthen standards for delivery of services in our country. But also still will require medicines and essential medicines, diagnostics, technologies and innovations. And we are working very closely with our partners and increasing on funding to these areas because they are very critical. We cannot do without them, and we need to see how to work very closely in that area. And in the interest of time, I can also highlight that we really need to emphasize data use for program evaluation and monitoring, and also for decision making. And digitalization will help us a lot in data use, monitoring, and evaluation. Thank you so much, Mark.
Thank you very much, Dr. Henry. I think that you've really highlighted a few things that I would want our next panel member or the discussant for this webinar to highlight on. So I will now invite Christina Yaro to give us a very high level reflection of after listening to all the game-changing trends, the questions and answers provided by our panel members. Can you please highlight, how current, potential innovations, including those implemented by the USAID projects, are addressing some of these emerging trends to strengthen our PHC system? And I'm asking this question also because, you're coming from the PHC level, and the fact that, we need to really understand what are some of the existing approaches that we can leverage. Over to you, Christina.
Thanks so much, Mark. And thanks to all the fantastic speakers today. Really, really fantastic remarks. So I'll dive in here a little. From December 2022, we had the US Africa Leaders Summit that really acknowledged that a resilient primary healthcare oriented system can improve life expectancy, increase health equity, and respond intuitively to disease outbreaks and emerging health threats. And all the way to Dr. Tedros's call to action to radically reorient our health systems towards primary healthcare. The calling is clear, as all of our discussants and panelists have said today. We know that there is no question what's being asked of the global community. The trends and examples highlighted in today's presentations are really potential game changers if we can get them right, if we can learn from them. So I wanted to share a little bit, as Mai mentioned, about primary impact. So through primary impact, USAID is working to accelerate essential health service provision by leveraging and really coordinating our global health programs around country-led plans for strengthening primary healthcare, starting with 7 focus countries across Africa and Asia. We have Cote d'Ivoire, Ghana, Indonesia, Kenya, Malawi,
Nigeria, and the Philippines. And we're really working with government counterparts and local partners, including civil society organizations and their networks, to support implementation of these mission-led action plans that integrate our investments across the technical vertical funding streams in key intervention areas and sub-geographies that really address country priorities for PHC, country-defined plans and strategies. We have action plans that outline a 2-year strategic vision that really leverages USAID's comprehensive health program footprint and advances coordination with donors as well, such as the World Bank's Global Finance Facility and the Community Health Delivery Partnership. And this work all demonstrates USAID's commitment to primary healthcare and calls for partners, all partners, to align to one team and one plan, which is essential. We also have, another game changer innovation development that we have is the U.S. government's Global Health Worker Initiative that plans to support governments and multilateral institutions to build sustainable health workforce, right, to address the estimated shortfall of 10 million global health workers by 2030. But another piece that I wanted to reflect on that came up time and again today was really the investments in technology and innovation are core to all of these initiatives to supporting a standardized, remunerated, strong, adaptable, supported health workforce, especially equipping workers with the ability to provide more efficient, quality integrated service delivery using these digital platforms. And I hearken back to my time on USAID's COVID-19 response, and I was the deputy director there. And I can say that while the pandemic really wreaked havoc on systems the world over, innovation was born out of these difficult times as well. We learned a lot, we adapted, we innovated, and we worked with Knowledge Success. It's a 5-year global project led by CCP and funded by USAID's Office of Population and Reproductive Health to support this learning and documentation and knowledge management, and created opportunities for collaboration and knowledge exchange. And we developed this essential resource collection focused on the integration of COVID into primary healthcare. It includes country case studies, resources on supply chain, digital health solution, reaching priority populations with vaccinations. And so it's just an example of one of our USAID projects that really helped to add to the resources here. And then another one I wanted to highlight, if I have time, our colleagues at WHO and UNICEF, with funding and partnership from the Gates Foundation, developed this geo-enabled microplanning handbook, which aims to provide health officials with guidance on how to integrate geospatial data and technologies into the microplanning process. And I found that really a unique opportunity to, while vaccination campaigns are most commonly equated with microplanning, it can go for so many interventions to disease prevention, mass drug administration, nutrition supplementation campaigns, TB, et cetera. Really digging down to the microplanning level, I think, is essential, because that's where we meet the communities and the populations we're meant to serve. So data-driven health systems help ensure efficient and effective collaboration, allocation, and prioritization of really limited health resources, whether it's health workforce, medical products, infrastructure investments. And having access to this kind of data, this kind of mapping and analysis, can improve equity and quality. And I think I heard it mentioned today, we need to grow a data use culture in the communities themselves where services are delivered. And this is essential to advancing primary health outcomes. I have more comments, but I know my time is limited. So one more piece. I had the opportunity to attend the Standing Committee on Primary Care yesterday, which is U.S. government's own initiative around strengthening primary health care. And I was really pleased to hear us here in our country reorienting our thinking, re-engaging in what is defined as the medical neighborhood, engaging in more improvement science to really drive progress in the whole person care. And how do we do this? With community coordination, practitioners understanding what matters to a person, using the tools to support mental health, lifestyle changes, and dealing with some of these really difficult questions. So it goes back to really integrated, community-centered, and client-focused health services. It's one of the critical interventions. It is not new, but we need to innovate and adapt and do better. That helps us to drive accountability and collective responsibility of our health systems from the point that matters most, which is the whole person. Thanks, Mark.
Thank you very much, Christina. I think you know, your key highlights and intervention now had provoked one critical question, but it's very specific. I think it's coming from Kenya, and I would want you, before you feel comfortable in your seat, before that try to highlight or speak to the question. So there's one of the participants is asking that Kenya is currently having a moment in history, and I suppose the moment has to do with the PAC law that has recently been passed, the social health insurance as mechanism that was also enacted as a law. And the question is, I would like to know how the USAID is positioning itself to be in the driving seat, given the enormous resources that are needed to make these implementations happen. So I don't know if you have specific question, a response to that, but otherwise, we can find the respective person and engage later on. Will you want to make quick comments on that, Christina?
Sure, I'm happy to. I also looked to Mai and others on the panel, but in Kenya specifically, I think one of the best opportunities we have is that the government is making these changes. The government is leading on this. The new cadre that has been brought about, the community, the CHPs, is an incredible opportunity. Even that alone can galvanize donors to look at what cadres of health workers they're funding, to reorient some of the ways in which we are supporting country plans. The primary care networks is another fantastic example, and really digging down to sub-county levels to look at really how financing is organized, how those primary care networks and the multidisciplinary teams that support those networks are operationalized, supported, upskilled, et cetera. So I do think that the country's leadership is absolutely key, and it's an opportunity for all of us to really be aligned. Thank you.
Thanks again. I think that we are running out of time, and I will give my the last two comments to Mai and Judith. If you have a quick word for us, as we all looking forward with a lot of enthusiasm about the opportunities that PHC is presenting us. If you have quick comments to highlight, that would be great. So Mai first, and then Judith. Over.
Yeah, thank you, Mark. And I just want to say what we see happening in Kenya is so exciting.
I think, Mai, you are on mute.
Yes. Whilst we're waiting for Mai, Judith, if you have a quick, last comments before we get the feedback from Mai. Over to you.
Thank you so much. All that I can say is that, as has been alluded to, PHC is now the in thing in Kenya, and we have the support from the top leadership. And recently, we are happy from the National Treasury and Economic Planning. We are working jointly with the Ministry of Health in planning, prioritizing, financing, and monitoring and evaluation of the health outcome. We recently had a dialogue session courtesy of the African Economic Research Consortium under funding by USAID, and this helped us to clearly understand what PHC is. So when you go to prioritization of resources, at least we have a common understanding on what we are funding and perhaps the expected outcomes. So we'll be able to ensure there is efficiency and accountability in the resources we allocate for PHC. And we'll use the frameworks like the integrated financial management system to ensure there is accountability, and also our national integrated monitoring and evaluation system to ensure that we get value for money in terms of financing PHC. Just to mention, with regard to autonomy at the health facilities, we realized that our facilities were not getting the funds like they need to be able to improve on the management of the health facility. So we are glad that there is a Facility Improvement Financing Act that will allow public health facilities at the county level to be able to retain, manage and utilize the revenue derived from the health-related services to be able to improve on the health facility. And as I conclude, we see PHC as a means of alleviating pressure in our hospitals and clinics, and it will also allow our citizens to make healthier choices. So we need, it will help improve the health continuum from birth to old age. And this is what we need in terms of improving our productivity, and in turn ensure that we achieve our transformation agenda, because it's based on human capital and quality of life for all the citizens. Thank you.
Thank you very much. I'm sorry that we would have to end this very interesting conversation. There are a few questions that came from the audience we couldn't tackle. I think we will find appropriate time to write them up. Maybe in the YouTube post of this session, we can attempt to answer them. But I want to thank all the panelists and our experts for sharing, their perspective to this. And I'm happy that, they just perspective. We know that there are various innovations that are being implemented at the country level. Please share with us. But I want to express our sincere thanks to especially our country government partners, Uganda, Dr. Henry and Judy, for making time to share with us today. And of course, for our funders, Mai and Christina, thanks a lot for joining us today and sharing the vision of the USAID, especially when it comes to PHC and health systems. I think this conversation is just begun, and we would have other opportunities to keep discussing and engaging with it as we find better ways of leveraging our PHC for the full continuum of care and ultimately provide the quality of essential healthcare we need for our citizens and population. Thanks once again, and I wish you all the best, and stay in tune for our next webinars that would be taking place in a couple of weeks, months, and we will let you know. Thanks again. Have a good day. For those ahead of us, I think you have a good evening.